type clothing. Cotton underwear is better than silk and the rest of the materials. Cotton underwear is preferred. No soapy bubble baths. Clear water only. You're teaching a patient about preventing vulvovaginal infections. Clothing that allows things to circulate. I'll tell you a quick story. My sister was a roommate when she was in college with 5 other girls, and one girl, the first time I met Tammy, she was laying on the bed trying to get her jeans zipped. So she was going from a 0 to a 2. Why did they make a size 0? I don't really understand that anyways, but anyways. So her friends are helping her get her jeans zipped. Tammy. And then my sister said she would like have jean marks for like 24 hours on her legs when she would come back from bar hopping. I'm like, she's probably a candidate for vulvovaginal infection, right? And so anyways,
They didn't have stretch back then.
they didn't have stretch back then, you're right? Like things were not that cool like they are now. Yes, there's lots of factors. But I was in high school, and that's why I was not allowed to go to a big university because my sister. I still blame her now because my mom was like, "There's no way that she's going to send me to university with the Tammys of the world." So, anyways, Tammy moves out. One semester in, she moves out of that house, and we always wondered what happened to Tammy. She joined a sorority, and then they called her Good Time Tammy. No kidding. Fast forward some years, and we still laugh about Tammy. And all of a sudden, the Love Connection was on. Have you ever watched that show?
Oh, I know what it is.
You know what that is? For those of you who don't know what that is, this is before online dating, right? They had a person on the show, and then you had 3 people. Like if you were trying to find a date, like they would have you on the show, and they would bring 3 males in, and they would introduce themselves in this little video, and you have to pick which one that you want to go on a date with.
And they paid for it.
And they paid for it. The show paid for it.
Yes.
Correct. And then you come back after your date, after you pick. And the audience could vote, I think.
The
too.
audience could vote.
The audience could vote and say, well, you should pick Joe to go out with, and then you come back on the show, and then they would say, well, how did your date go with Joe? And then you could talk about your date. Good Time Tammy was on that show. Kid you not. So we're now, she's now like 25, and my parents recorded it, which is also cracking me up. They recorded Love Connection. Us before online dating, so,
Yeah,
and it's entertaining, and then we come over to my parents, and my mom was like, you guys have to watch the Love Connection that we recorded the other night. And we're all like, this is the stupidest show ever. And then I was like, oh, there's Good Time Tammy. She told me so. She looked like she was still at risk for this infection. I'm just saying. And she was like, in California with the raspy boys. We laughed. But when I think about this slide, I think about Tammy.
Now I want to see who Tammy.
Okay.
Tammy looks
I
like.
see, right? I don't even know
Trying to
what
find her.
Wait, make sure we say anything.
Good Time Tammy. Oh my gosh.
She's the one that got her
We just laughed
name
so hard
written on the
because
back
there
of
she
the
was.
stall.
And her dad was a Jack. And he's a coach there. And she
Tammy.
wanted to be a Dallas Cowboy cheerleader now, which she made that.
She's a cheerleader?
I was at that university. My mom was like, no, you're not going to that university. You're going to degree.
Was her last name Love? Tammy Love?
Kevin.
What was her last name?
Every once a week. So therefore, all my university memories that I could have had, I'm blaming on Good Time Tammy.
You could have been Good Time Tammy.
You could have
I
been.
know, I could have been. It would have been a lot more fun, right? Anyways, I wouldn't be a nurse. I'd be doing something else. Okay. I digress. Any questions about preventing vulvovaginal infections?
So funny.
Okay. Fistulas, by definition, fistulas is when you have an opening between 2 parts that aren't supposed to be connected. When we talk about fistulas. We had a patient once that had fecal material coming out of her vagina. And because she had a fistula that was attaching those 2 parts, she had it for like 6 months, and she didn't go to get it fixed or addressed because she had no insurance.
Oh.
So, our job as nurses sometimes to help people through some of those things. What kind of programs do we have that might have been able to cover your treatment or make something else an option for you? we can offer dietary recommendations, you don't need to know any of these. This is what falls into low residue diets. There's lots of great resources out there. If you need to know something dietary specific today, I'll tell you. These are when the pelvic organs prolapse. Prolapse means they fall down into cavities, they drop down into cavities instead of being suspended up where they're supposed to be. Pelvic pressure. Uterine prolapse is what we see related to this more specifically, because for a female's uterus is supposed to be held up there with this real big ligament held up here in place. If the female has had big babies, multiple babies, that ligament doesn't hold it tight anymore, and that uterus just starts to drop down. It's like that rubber band gets saggy. And then their uterus starts to fall down onto their bladder, onto things like that, because that ligament's not keeping it up, suspended up there where it's supposed to be. There are different things we can do. We can teach them how to strengthen their vaginal. The female says, gosh, I just feel like the bottom's falling out, or I know that you told me my uterus is pressing on my bladder, and I always have stress incontinence, things like that. Well, we can teach you things to strengthen your vaginal muscle walls, bless you, including Kegels. How do you teach a patient how to do Kegels? Pardon me? Pretend like you're urinating and then you're stopping your stream. Squeeze on those muscles, right? So pretend like you're urinating or urinate and try to squeeze your muscles together and tighten those up. We can also put in combs and rings and things to keep that uterus pushed up back into place, off the bladder, off the lower pelvic cavity. Wash those, clean them as prescribed. There's other laparoscopic treatments we can do, lots of other stuff. Uterine prolapse, that's the one I just talked about. Instead of that ligament holding that uterus up in place, that rubber band's gotten saggy and that uterus is dropping down, and the patient's dealing with a lot of lower pelvic pressure. She'll come in and say, I feel like the bottom's falling out. Yeah, probably because your uterus actually is sitting real down low in your cavity. Urinary incontinence is not that unusual. Again, that uterus is sitting right on the bladder. The patient can't retain urine. There are surgeries. A colporrhaphy means repair. O-R-R-H-A-P-H-Y. That is not removing your uterus. Basically what this procedure is going to do is tighten that ligament back up, strengthen that rubber band, get your uterus pulled back up in place. It's a repair of your uterus. It's going to no longer be sagging in your pelvic cavity. We're going to take that rubber band, tighten that up, and pull that uterus back up. We can do a colporrhaphy a couple of different ways. We can do it anteriorly, posteriorly, monitor post-op bleeding, but that's what that word means. If it's significant enough, an uterus is sagging down into the pelvic cavity, and the patient doesn't want to have any more children, we could possibly talk about doing a hysterectomy, just remove the uterus altogether. So there's other options. We can put in a mesh bridge, which is like a little net, or we can pull that uterus back up into place. So there's lots of different treatment options. We don't have to know this one specifically. Some of you may have seen on commercials or otherwise that they developed that mesh sling, and the sling would be used to put underneath the uterus to pull it back up. And then we started having complications with the slings, and there were lawsuits and people having infections and a lot of complications related to that. Do your homework, figure out what surgeon you want to go to, see what kind of ratings he has, use an academic site to do that. Lots of things we can do now we have access to where you can figure out if that's the healthcare provider you want to go to. If you don't have a very good feeling about your healthcare provider, provider, you're always welcome to a second opinion. Questions about uterine prolapse? Somebody asked me once, you do the short straw, why do you have to do reproductive? I don't know why. But this is the last semester because next semester it's going to a different, it's going to 165 or something. The last time I had to do this lecture ever. Okay, vulvitis is a chronic pain syndrome. Lots of causes, lots of things going on there. A Bartholin cyst, your Bartholin gland is what provides lubrication during sexual intercourse. If it's a cyst, sometimes we have to just lance it open and drain it. We'll biopsy it, of course. Vulvar dystrophy is dry, thickened skin, usually older women. Corticosteroids, sometimes a good option for that. Ovarian cyst can mimic appendicitis pain if it ruptures, usually benign. Anything that's usually benign still warrants diagnostics and evaluations, right? Because we can all do this actually. And as nurses, we don't ever reassure patients, say, oh, I'm sure it's benign. No, we don't know that. Poly means many cysts on the ovary. Your patients may come in and say they had irregular menstrual periods, or my spouse and I have been trying to conceive a child, we've had no luck, and sometimes this is the culprit. And like I said, if I don't spend much time on it, then it's not as important as other pieces we're covering. Here are risk factors. This patient is at increased risk for endometrial cancer because with this syndrome they don't ovulate and the whole hormone cycle is messed up. Fibroids, almost always benign. Again, the patient may come in and say they're having trouble having children, conceiving a child, and that may be the reason. Abnormal bleeding is sometimes related to the fibroids. They can be lots of places, lots of types. Fibroids are very vascular. Fibroids are very vascular. So what do you know about that as a post-op nurse?
Bleeding.
There you go. What other indications of bleeding besides blatant vaginal bleeding? Low blood pressure, tachycardia. Why do you have tachycardia anyways in that case? Correct. Your heart rate goes up because your heart is trying to compensate and it produces more blood. What's another lab value? Hematocrit and hemoglobin, exactly. So as a 265 student, the answer will probably not be that there's just a gross amount of blood on the bed sheet. What other indication are you going to monitor for as her post-op nurse, post-procedural nurse, that may indicate she's got increased bleeding going on? All those things you just said. But sometimes those are such subtle things, and sometimes we don't always pick up on those. And when you're assessing bleeding vaginally, I've seen you turn on your side, I need to look behind you, I need to look underneath your bed sheets to make sure that I'm not missing something. Usually they shrink and disappear during menopause. The pain sometimes is worse with each menstrual period, just because the fibroids feed off of the hormone intake. So the hormones ramp up for the menstrual period, the fibroid pain gets worse, they have a menstrual period, it goes back down. So therefore, sometimes, because they feed off the hormones when the patient goes through menopause, sometimes those fibroids are just done for. They just disappear on their own. And there's other medications, things. This is in red. So you've done hysteroscopic surgery using a scope to manage this patient's fibroids. And you're going to watch for post-op complications. As you can see, a lot of those are related to bleeding, hemorrhage, increased menstrual bleeding, increased bleeding afterwards. The the patient still has menstruation even though they have their uterus tumor removed. Most of those are pretty common. Fluid overload, because a lot of times when they do this procedure, they'll put a lot of fluid into the abdominal cavity to irrigate. After the procedure, irrigate blood clots and stuff like that out, irrigate to get the fibroid tissue removed, and therefore then the patient may retain that fluid as a complication. Endometriosis is when you got endometrial fluid tissue, and endometrial tissue, that's not where it's supposed to be. It's supposed to be within the uterus, and it's in other areas outside of the uterus. The patient has severe menstrual pain, increased bleeding. They may not be able to have children, conceive children with endometriosis. And I'm not worried about any of these meds for you right now. We're gonna talk about oral contraceptives, why we use that for sometimes when the hormone cycles are messed up or causing severe pain. Chronic pelvic pain is we can't really figure out why you're having pelvic pain. It's not necessarily the menstrual cycles where you have influx of hormones. We just don't know, and we don't know how to treat it. We don't know how to diagnose it always. This is tissue that's supposed to line the endometrium to the uterine wall. Hyperplasia, as I said, is plasia always means abnormal cell growth somewhere where it's not supposed to be. This is a precursor. Hyperplasia typically is a precursor to a cancer, or it's atypical enough that we need to evaluate it because it means the cells are behaving in a way that we don't want them to, or they're going someplace that we don't want them to. Cervical cancer, if the patient has been pretty faithful about having pap smears regularly, a lot of times we can detect atypical cells. We can identify cancer early, we can diagnose it early, we can treat it early, and the prognosis is usually good. All of those things being a part of that, right? There's females that don't go in for pap smears for lots of reasons, and therefore sometimes we can't detect it that soon. So as the nurse, promote prevention, screenings, education. Education doesn't mean compliance, as we've talked about. Just because you know you should have that done every year doesn't necessarily mean that you should, but as your nurse, I'm gonna educate you on the importance of it, why those things are necessary, why they're recommended, how the procedure will go, who can do it for you in your area. Here's a list of healthcare providers. Try to do everything you can to increase the likelihood that that female's gonna go in and have her pap smears done as recommended. Clues. For the cancers today, the different ones that we'll talk about, one thing that you need to know is there a certain age group, and what age groups get cervical cancer typically?
20 to 50.
Childbearing years. And that's why we do pap smears for those years specifically, so that just makes sense, right? So childbearing years, so age groups for the cancers, primary symptoms. For this one, the patient reports watery discharge after sexual intercourse. If it's advanced, the discharge being turned from watery to dark and foul smelling. Because after sexual intercourse, there's been trauma to the cervical tissue, which is abnormal, sensitive, and therefore the patient's got irritated cervical tissue following trauma. So bleeding after slight trauma being sexual intercourse, douching, or bearing down are the presenting symptoms. usually that goes with cervical cancer. Childbearing years, bleeding or watery discharge after mild trauma being sexual intercourse, bleeding, things like that, that change the cervical environment. Advanced, it goes from watery to dark and foul smelling. Bleeding between periods, because that cervical tissue is not typical, not normal. As things progress, more significant symptoms. If the cancer is contained within the cervical tissue area, if it's been identified early, the prognosis is usually great. Early identification, contained to the area, that's what INSITU means. It means localized, it's not spread. And treated, the prognosis is usually really good. There's lots of things we may opt to do if it's identified. And keeping in mind, if it is a childbearing years, we need to find out if that female wishes to have children, and that's going to impact what we decide to do as far as uterus goes. Okay, cancer of the uterus, different age group, typically after menopause. Cervical cancer were the childbearing years, cancer of the uterus is post-menopause years, different population. Risk factors for this and breast cancer, when we get to that, is how many menstrual periods the female has had. Increases that female's risk. So nulliparity means what? No kids, correct. So if she has had no children, she's had a menstrual period every day, every month, for years, as opposed to this female who's had 8 kids, right? So nulliparity is a risk because of the number of times that she's been through that hormonal cycle in her life. So nulliparity is a risk. Early menarche. So you say, when did you start your menstrual period? Because you started at age 10. She's had a lot more menstrual periods than the 14-year-old did when she started at age 14. So you're the nurse, you're calculating risk factors. She says, I have no children, I've never been pregnant. Well, you have more risk factors because she's had menstrual periods every month, not any time when she's not had menstrual periods. And the girl that says, I started my menstrual periods at age 10 or 11, that's early. And she had a lot more menstrual periods than the girl that started at age 14. Do the math, just calculate them up. One doesn't negate the other one. So just because she started at the age of 10, but she has other things, if you're counting risk factors, you had a lot of menstrual periods, so I'm going to count that as a risk factor. So if you're calculating risk factors in a few weeks from now, and you're trying to figure out how many menstrual periods this girl has had, you will be given an age of 10 or 11. It won't be 13. But, oh, is that early or not early? It'll be early enough if you're counting it up to say, oh yeah, she's had a lot of menstrual periods compared to a 14-year-old. Does that make sense? And we can argue or talk about and say, well, what if they breastfed? They didn't have menstrual periods then, right? As a nurse, that's a great quality to have. If you're taking through all of them. As a student, don't go there, right? Because you could just talk yourself into anything. As a nurse, that's a great things to think about. Well, she breastfed for a year, didn't have menstrual periods. As a student, just don't go there. Just count up how many menstrual periods that female has had and stick to the risk factor list based on that. Otherwise, you're just gonna talk yourself into, you're gonna go out somewhere. And then maybe you have to test it. Well, I thought since, I was like, oh my gosh. Questions about that? Again, it's the presenting symptom will be the patient has been through menopause and all of a sudden I started having menstrual bleeding again. That should red flag for you that there may be something going on there. Because after menopause, they should not ever have any more menstrual cycles or bleeding again. We can do a biopsy, as we've been talking about, no douching or sexual intercourse. I had a student once that said, this is a stupid question, why do people even douche anyways? That don't even make any sense to me. Sometimes females like to douche to feel like they're clean, Sometimes they feel like after menstrual periods, they wanna douche, so they feel like they have just got fully washed up, cleaned up, stuff like that. But douching changes the environment, the vaginal environment, and that's really not recommended to do on any kind of routine basis by any means. And we could do lots of treatments. We can monitor their CA 125 levels. CA means cancer antigen. Screening. We'll get to some treatments and some of that kind of stuff when we get to oncology. So we've been through cervical cancer, we went through uterine cancer, now we're in cancer of the vulva. It's rare, I'm not gonna spend any time on it. So is cancer of the vagina. So is cancer of the fallopian tubes. We will spend a little time on ovarian cancer. Most are diagnosed between the age of 50 to 60. So we had cervical cancer from childbearing years. Uterine cancer was typically postmenopausal. Ovarian kind of somewhere in the middle there. Again, the more menstrual cycles she has had, that increases her risks. So she started her menstrual periods early. She had late menopause, which means if she didn't go through menopause when she was 58, she had a lot more menstrual periods than someone that went through menopause earlier. No kids, older age. Who is a first degree relative? Mom,
Sister.
sister,
The father.
daughter,
Yeah.
correct. Grandma doesn't count, Aunt Sally doesn't
Oh, they don't
count.
have a word. They don't have a word.
First degree
I'm
relative
thinking
is
breast
mom,
cancer.
sibling, child. Don't count grandma in that risk factor, aunt, anybody else. The problem with ovarian cancer is there are symptoms, but we don't recognize them as being a reproductive cancer, because it's abdominal issues. So the patients have bloating, the patient is constipated, feel like has a lot of gas. So what happens is the patient experiences those symptoms because they're not typical reproductive symptoms, as in bleeding after discharge, stuff like that. So then they may change their diet. Well, maybe what I ate is kind of making me have gas, so let me change my diet for a while. So typically the patient will do that, or they'll have increased fluid in their increased enlargement of their belly, even though they haven't gained weight anywhere else. So then they may change their diet for a while. They may go to a GI person for a while. And now we're a year after the symptoms have presented themselves. And so we really think about ovarian cancer. So what's weird about ovarian cancer is it's GI symptoms. So the mnemonic is BEAT, bloating, eating less, feeling fuller, abdominal pain, and trouble with the bladder. So age group 50 to 60-ish, presenting symptoms, they're there, but we don't recognize them because of the GI stuff. Therefore, the prognosis is usually poorer because it's more advanced oftentimes before we have identified it or diagnosed it. Because it's abdominal stuff, it's approached from a GI standpoint. So if you ever go in for your clinical exams to your OBGYN, they may ask you, are you having any trouble with bloating, any trouble with a lot of gas? That's what they're getting at, to see if there's anything that may indicate that you have ovarian cancer. Because it's always a weird thing going through OBGYN and asking all this GI stuff. That's what they're trying to figure out. Recurrence is common. Usually, again, the prognosis is usually poor because it's advanced before we identify it. Late diagnosis is problematic. The diagnostic test for a lot of these is that CA 125, the CD cancer antigen. Those of you who watch Saturday Night Live, Gilda Radner was on the old shows a long time ago. She died of ovarian cancer. She was a favorite character on there when it first started to broadcast. And so there's a Gilda's Club, lots of things. And that's the first time I think people started even hearing about ovarian know the age group, know the presenting symptoms, is probably my biggest recommendation for you for keeping those straight. Not the rare ones, I won't ask you about those. Hysterectomy, again, preoperatively, nothing's gonna increase their risk of bleeding. No vitamin E. Vitamin E prevents platelet adherence. So that's why vitamin E is on that list as well. So what are the 3G herbs again?
Ginkgo biloba.
Ginseng,
Ginkgo biloba.
ginkgo biloba,
Garlic.
ginger, vitamin E, NSAIDs. Tell me some names of NSAIDs. Ibuprofen, naproxen, all of that list, correct? Anticoagulants, tell me some of the names of some of those.
Warfarin.
Warfarin, tell me the ones that aren't as obvious as warfarin. Xarelto, all of those ones that we see advertised. So you're the pre-op nurse. You're preparing your patient for her scheduled hysterectomy. You're gonna tell her to withhold which of the things that are on her medication list or on her herb list. Could you identify that given that situation? Not that it would be a psychology apply, but sounds like it could. Hint, hint, hint. And just remembering that all of these things are really emotional for that female, right? So sometimes I think we get to our little checklist, we see on the laptop, and we're like, yes, no, this. And well, we're gonna schedule for some follow-up. We found something that is a little bit unusual. They all know what that means, right? So recognizing the emotions that go behind all of those things are super important. When you're asking a female about sexual intercourse, when you're asking her about tampon use, when you're asking a 14-year-old about her menstrual periods, all of those things get to be pretty private for a lot of people. So approaching those topics with really careful compassion is what you need to do. And there's people that just don't wanna talk about any of that stuff because that's just how they raise. I had a mammogram done once, and then they thought I had fibrocystic breast condition. So I have a mammogram done, I don't wanna get them done anyways, and I get a call on Friday, and it said, this is scheduling. We were told we needed to have schedule you for a follow-up test. I'm like, I know what that means, that's probably not good, right? And so I see the call comes like, plugged in, I unplugged it because I didn't want to step on it. So I see this call from Upper Valley, right? So that's not ever good anyways. So I'm sure it's gonna be doomsday. I call back. It's a Friday afternoon. We are closed for the weekend. This is an emergency. So now I'm sure I'm gonna die that weekend. I'm sure it's gonna be a problem. I'm sure I got breast cancer and it's advanced. So that weekend our friends are planning vacation. I'm like, nope, I'm not planning any vacation. I'm sorry, I'm not gonna be around anymore. So, so Monday morning at 7:59, I call it restoration office. I'm like, okay, yes? And she goes, what's your name? Oh, I have to schedule you for an ultrasound because you have an abnormal mammogram. Okay, that doesn't feel that good, right? Like, when can I get it done? 2 weeks from tomorrow. I'm like, I'm not waiting 2 weeks. I'm sure I'm gonna be around in 2 weeks from now. So, please schedule before that. I don't think I have anything before that. This is urgent, I need to have it done like tomorrow, today. And I said, "Call me Monday." No, I have clinicals on Monday, for God's sakes, just make it tomorrow, I'll be done with it. So for 2 weeks, I was pretty sure that I had breast cancer, right? And then as I watched the tech doing the ultrasound, I'm just watching her eyes. And I'm trying to see, and then she's moving the ultrasound machine. And then I say, okay, so what'd you find? She goes, I can't tell you. I said, come on, how long have you been working here? I've worked here for a long time, I know you've been here a long time. She goes, I've been here 18 years. I know you know what you're looking at. I'm like, she goes, I can't tell you. I said, close the door and tell me. I won't hold you to it if you're not telling me the right thing. So for 2.5 weeks, I was like nuts over bell, right? And I'm educated, and I'm a nurse. It's like, oh, for God's sakes, let's settle down. That makes it worse, is right. Because I did this like, you're right. Needless to say, fibrocystic breast examination, blah, 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 it's just fluid fill, this, nothing, should wait Dr. Meschberry to come in. So, that was me as a nurse, like, probably knew better. And what about the person that doesn't know any different? They're the one that reads up all that stuff on Google, everything they can possibly come up with, and they're sure that it's going to be diagnosed themselves.
Ooh, that's me every time I read a chapter. Every time.
So be on the receiving end of that. If you're the one delivering that information, if you're the one that's working with that patient, put yourself in their shoes. I'd rather have the healthcare provider office call me and say, this is what we found, we're gonna have scheduling call you and set something up, versus the lady in scheduling who just says off the top of her head, tells me that. So just be cognizant of all those pieces, because they're a big deal to the person that's on the receiving end. And needless to say, that's been 2 years ago, I went on vacation. I'd be outside, oh my God, I'm like, I'm ready for vacation, okay. I know there isn't, but I really wish the healthcare provider person, nurse, would have called me first and said, instead of somebody from my station to say, oh, you may need, I mean, that was my take on it. It's like, okay, can you explain to me exactly what you found? And then schedule will be calling you later on today. I know they didn't know, that little thing. I mean, I didn't expect it to work on like,
It's not their fault either, but.
I know it's not their fault. But it would have been better coming from a nursing person or somebody that would say, don't alarm. You don't really think it's anything that's a big deal, but we do
What
want
was
to
that
just follow.
movie?
That would have felt better
That
to me
movie,
than,
there was a movie where
and now, there's probably no right way to do that. So I went off on that little thing,
and she goes and
sorry,
spends
but
some money.
just, and if you're
Then
getting
it was
burned
in
out,
state or something.
and you're tired of working in the OB/GYN office where you are, go find another setting that's gonna work better for you. You know, my take is, if you're starting to not feel compassion for your patient, there's all the other opportunities. Okay, questions about that? Most important parts of that section. Tell me something off the top of your head. The cancers for sure. Presenting symptom, age group, CA 125 is a cancer antigen test that we will do. Leading after any of those procedures, always things that are going to increase the risk of bleeding when you head into your procedure or surgery. What kind of things do you have your patient hold and not take?
Sorry, guys.
It's okay, you're okay.
Anybody else have anything from that section you have questions about?
Oh, that's pretty funny.
More menstrual periods you have, they increase risk. So when you see that the patient's had null parity, early menarche, late menopause, those just tally up. The more hormone changes that female has had in her life, the increased risk that she has for those kinds of things. It probably would, but don't go there in 2 weeks from now. Yes, all those things are probably factored in, you know, she's on, the question was, well, she's on birth control, then had menstrual periods, would that decrease her risk or would it increase it because she's taking hormones? You know, it's probably, I don't know. That's a great question as a nurse.
That's what I was thinking
That's a
too.
great question as a research person, but as a student, y'all go there. But that's a great question because those are valid. And some of you that work in a research lab at some point in time, those are great things to factor into all of your thoughts about what increases the risk.
That's why when you haven't had kids.
Okay, I'm just gonna keep going until I see, well, here.
Okay.
I'll digress a little bit maybe before I start this section. Sometimes some of you, even within my clinical group, are getting, we're worried about, what do I have, what do I put on my sheet for the 275 practicum? There's only so many sites, put what you want on there for your request. It's 96 hours, it's not the end of the world. If you get placed somewhere where you didn't really wanna go there, just make the best of it. And sometimes students say, I wanna work OB when I graduate. They have their practicum in OB and then like, oh gosh, I do not wanna do this when I graduate. It's a good time to figure that out, right? Or if you say, I don't know, I might wanna work ICU. Well, if you think you might wanna work ICU, just request that for your practicum. You'll have good experience, you'll have good knowledge, and then you'll know when you get done with it, ER setting. And I had a student once that said, hey, I heard that you gave input into whether I should be in ER, and I said, yeah, we did. Because we don't wanna set you up for unsuccess. We're gonna be setting up for out there and then rounding in the setting and about 20 minutes. So sometimes there are students that just change gears faster, like that fast pace, that's kind of how they roll, and some students are much different, other strengths. So yes, that time they laid out 4 student files, and they said, any of these probably better, good candidate for ER placement or not. And it doesn't mean that you're a lesser of a student, because you're not that pace. We're all wired a little bit differently. So, when they come in and talk about that, don't get anxious about it. Put your request out and you have it. Don't lose a lot of sleep over it. It'll all work out. And it's 96 hours. So, you can, yes, you can fill up. You got to take first, second, third. They'll explain that part to you. And if you turn in your request sheet and then over the weekend or something, you're like, oh, I don't know if I really want to do that. You're always welcome to email Mr. Roberts and say, hey, change my mind. I put that down, but I don't really. And I don't think they tell you where your place is anywhere. Because it has to be a preceptor, there's kind of a lot of process for that. So they don't give you something and tell you what you're gonna be in the first half. You're gonna be studying and then you'll find out that that's not gonna be the case. So, the practicum occurs in one half or the other. Your 96 hours a week, the first half. The other half is the lead. You don't have any monsters on clinical days. And you don't have clinical instructor any longer. We'll take advantage of that. I know, it's crazy, isn't it? It's kind of nerve-wracking, but in nursing, you always have people around you. You always have a team, there's always people to, and I would get an interview question. An interview for your first job. Who's here when I'm here? Who's my mentor during orientation? Who's my mentor when I'm done with orientation? Who is in-house? When I'm here working at 2 in the morning, I need to get hold of somebody. Who is my go-to people after my orientation period is done? I really wanna take really good, safe care of your patients. So I need to know who my resources are that can help me out with that while I'm here taking care of your patients. If I were your potential employer and you told me that, I would say, gosh, that feels good that they really wanna be safe with the people that they're taking care of within my institution, so. And your license, you work too hard for your license to be stuck in somewhere where you think, I have nobody to call. When I applied for my job here, I applied for a night supervisor job at a nursing home and care facility. Why I had that thought, I'm not sure, but. So I applied for it, and then I got this anonymous call from a staff member who heard I had applied for it, and she goes, do not take that job because you are the only RN here on nights and you're over 60 clients. Something crazy. She said, you are the only nurse that's gonna be here for your 12 hours. I said, is there a supervisor or anybody else? Nope. And the supervisor you'd be working for, she's not really known to answer the phone. I'm like, okay, yeah, thanks. I said, is there a doctor? She would probably send care facility. No, there's no doctor in house. I said, who's with me? A couple of nursing assistants. I'm like, oh, me and 60 clients, no thanks. Ask those questions so you don't run into that same scenario. And we used to, during orientation, we pull people out of orientation and we pull staff. And they say, we're in your orientation. I know you've been in for a week, but we're short staffed on the floor today, so you gotta go take care of patients by yourself. And then we'll put you back in orientation. You're like, oh, God. So, ask those questions so you're keeping your patients safe. Your preceptor